People need to be able to access whatever it is that you are talking about. People need to be able to find it. You know, I was at a presentation where a particular cardiologist said, your product is as good as the patients that can find it. If the patient cannot find it and use it, then your product is not necessary for us. So we have this series coming up. Some of the dates may change. You can see we are in number 2 already. For the next one, we'll be talking about the drapes. For those that do not know about the drapes, you'll be hearing about the drapes at the next webinar. You'll be seeing practical demonstration of how to use the drapes. And then we'll talking about, for the last one, we'll be talking about financing. That's what we're talking about when it comes to the last one, financing. Some of the realities that we face here, studies have shown that 7% of the time, hospital staff are looking for supplies. I've worked in the hospital before. I'm a pharmacist. I've worked in the hospital before. In fact, even as a mother, I remember when they needed to use independent for me after delivery, and they couldn't find it. They were calling this and calling that. Thank God I'm a pharmacist. I had to call one of my connects and get it myself. The gynecologist, Dr. Smith of the Smith Medical Center, was fantastic and allowed that to happen. Like, what we do, that does not necessarily need to happen. That's why we exist. We exist to make sure that via technology, whatever it is that you're looking for, it's available for you 24 hours of the day. You know, without affecting your payments, your revenue. We also have this data talking about the fact that $7.6 million is lost due to inefficient supply chain in the health sector. Supply chain has a lot to do. Supply chain, like the last webinar we had, we talked about not just, somebody's bringing it from somewhere. There's cold chain. Cold chain is also something, is also a part of supply chain. I mean, we all know that we use oxytocin. Oxytocin requires cold chain. No matter what, no matter where it is, whether it is in a rural area, mid-rural, mid-urban, or urban area, as long as there's a mother there, as long as there's someone that can take deliveries there, oxytocin will be present. But what might not be present is electricity. This study was published in 2025, and you can see some of the data here, telling us that number of mothers that receive substandard enterotonis, according to they were looking at able, right? 1 million plus. They were looking at, and then I said, okay, if there was adequate cold chain, because they were looking at using substandard enterotonics. That means at the point when they were doing this study, they were looking at how we have to give extra doses of oxytocin just to be able to achieve the effect that we want, because cold chain has been compromised due to epileptic power supply. So number of doses of oxytocin saved by using quality enterotonics. These were the ones that were not substandard, and then cold chain have not been compromised. That's 483,000. Look at total number of vital hours time that was saved, over 200,000, over 200,000 in terms of hours were saved. Cost of doctor's salary saved, $560,000. And even look at the number of postpartum hemorrhage cases that were receiving substandard enterotonics. So there's a lot in for anyone that wants access to this article, we'll share it. But one thing is sure, using substandard enterotonics can cost a life, can cost inefficient economics for a hospital. It can cost a family, the mother's life. It can cost a child the love of a mother for the rest of their life. So why would we continue to do this when we have something else that can be used? There's an alternative that can be used. And that's why we have this program that we are running, which is our own, which is what we call Safe Motherhood Powered by Field. As I mentioned, we envision a world where there are healthy mothers and there are healthy babies. They are receiving quality care from skilled health workers, and there is access to the medication available. Access is very important in Africa. There is access. So we are accelerating new and old devices into therapy. We are helping with financing for hospitals that require financing. community pharmacists or any licensed healthcare provider that require financing. We are very key on the license part. And then comprehensive supply chain solutions at scale. This is what we are offering. We're offering it in a bundle, which we'll be introducing after Professor Aimakhu has finished talking. We talk about the bundle, we talk about how we can access it, but we want to really focus on what can be done when there is no coaching. What can be done, what should be done when there's no coaching. And to bring that to let us know more about that, I'll be introducing our speaker for today. Is no other than Professor Christopher O.Aimakhu. He is the Professor Honorary Consultant Obstetric and Gynecologist, College of Medicine, University of Ibadan. He's second Vice President of SOGON, Society of Gynecology and Obstetrics of Nigeria. He graduated with MBBS from University of Ilorin in 1994. Had his housemanship and residency training at the University College Hospital, UCH, in Obstetrics and Gynecology. He holds fellowship of the West African College of Surgeons, National Postgraduate Medical College of Nigeria, and International College of Surgeons. He's a professor of obstetrics and gynecology at the Faculty of Clinical Science of the College of Medicine, University of Ibadan, and an honorary consultant to UCH Ibadan, lecturer for African University. He's an invigilator, assessor, coordinator, and senior examiner at the postgraduate examinations, both the West African College of Surgeons and National Postgraduate Medical College of Nigeria. He has also served as external examiner to both undergraduate and postgraduate examinations in many Nigerian universities. He has been the secretary of the NMA, Oyo State, secretary Western sector of the Society of Gynecology and Obstetrics of Nigeria, SOGON, board member in the Faculty of Obstetrics and Gynecology of both the National Postgraduate Medical College of Nigeria and West African College of Surgeons, and a past chairman, NMA, Continuing Medical Education Committee, Oyo State, amongst others. He is the immediate past Secretary General of the Society. Is the immediate past Secretary General of SOGON, and presently the second Vice President of SOGON. He is the chairman of the St. Vincent Continuing Medical Education Services. His area of sub-specialization is in maternal and fetal medicine. I mean, who best to give this and to host it? And research activities in this area cover antepartum, intrapartum, and postpartum issues. An area of research focus is maternal disease in pregnancy, as well as domestic violence and adolescent reproductive and sexual health. He has over 110 scholarly publications to his credit in peer-reviewed journals, local, national, and international. He has also contributed chapters to several textbooks in Nigeria, across Africa, and beyond. Professor Chris O.Aimakhu, like he's popularly called, has received many awards and has made several presentations at both local and international conferences, workshops, seminars. So permit me to welcome Professor Aimakhu to continue from here. Thank you so much, sir. Over to you.
Thank you very much. Can you hear me? Am I audible?
Yes, we can hear you.
No, good afternoon, everybody. I'm happy to be here. I would like to recognize the second president, Professor Okechukwu Ikpeze, who is on this call. I also like to recognize Professor Abiodun, the vice president, who is also on this call, and everybody here who has joined. Okay, I can see Professor Jamilu Tuko. It's good to have you here. So I'll be talking about beyond the cold chain, revolutionizing postpartum hemorrhage and its management in Nigeria with heat-stable Carbetocin. This presentation is purely for academic purposes and knowledge purposes, and I'm not doing it for the benefit of marketing any products. I also do not work for any drug company, and I'll try and make it as simple as possible. In my declaration of personal interest, I'm however affiliated to the University of Ibadan, where I work as a professor, the College of Medicine, the University College Hospital Ibadan, where I earn my salary as a consultant, and the Society of Gynecology and Obstetrics and Gynecology, where I am the present second vice president. For this presentation, we want to answer the question, why do we need to prevent PPH with its stable carbetocin? If we have other things that we're using, is there a problem with those, or why is it that we're not talking a lot about carbetocin? I'll follow these following outlines. My presentation will not be more than 35 minutes. We'll talk about heat-stable carbetocin. I'll make an introduction. We'll talk about heat-stable carbetocin. What are the figure guidelines on the use of heat-stable carbetocin as an alternative to oxytocin, the prevention of postpartum hemorrhage? I'll mention some studies on postpartum hemorrhage, talk about medical therapy for prevention of postpartum hemorrhage. In that aspect, I will also talk about the role of carbetocin. And I'll go through a quick case presentation just to demonstrate how it's beneficial. And then I'll make some recommendations and then conclude. I hope you can hear me. Am I in a silent room? Am I audible?
Yes, you can hear me.
Yes.
Thank you very much. So the way for introduction, obstetric hemorrhage is quite a challenging problem, especially postpartum, when we're talking about postpartum hemorrhage, which is defined as blood loss of 500 mils within 24 hours after birth, and is responsible for more than a quarter of all maternal deaths worldwide. Almost all maternal deaths, about 94%, we must take note, occur in low economic and lower middle income countries like ours, and almost 2/3 occur in the African region, with more than 2/3 due to PPH. It has a very devastating reality that it remains a widespread and persistent challenge, even in Nigeria. We see a lot of patients who are bleeding. Many times we can't even help them because most of them would have bled prior to coming into our facility, and then we'll start running around trying to see if we can save them. So it's a burden on maternal mortality, and it remains quite high, like I said, in Nigeria. In Nigeria today, the country accounts for about 29% of global maternal deaths, with PPH being a major contributor, consisting about 20% of these tragic losses. What's happening? We've seen all this, we've seen this before, saving mothers' lives, which was trying to see if we can reduce the amount of women. It's the World Health Program or World Health Organization way of trying to promotion to try and what's called a new global target, how to reduce the maternal deaths. We're having quite a lot of deaths, about 230 women die each day. And the global target was to reduce, the aim of the target was to reduce to less than 70 deaths for every 100,000 women by the year 2030, and therefore reduce the number of women that are dying. We're close to 2030 now, 5 years away, and I'm sure in 5 years' time, the World Health Organization, we want to assess whether indeed there has been an improvement or we have actually reached this target. If you look at out of these 830 women that die every day from childbirth, say about 1 every 2 minutes. And this was looking at reviews from when they started trying to keep tabs on these numbers. And they looked at between the year 2003 and 2009. You can see that postpartum hemorrhage or hemorrhage in itself accounts for quite a number of women. Like I said, about more than a quarter of all women that die. So annually, about 15 million women will have PPH, and about 75,000 will die. I'm sure there's nobody here who has not heard or seen a woman die of PPH. When you look at generally, it only accounts for around 2/3 of PPH cases, and which can also be caused by trauma to genital tract, whether cervical or other injuries, and then retained products of conception, or women we have rare women who have some medical disorders. And most deaths from postpartum hemorrhage could be avoided through the active management of third stage labor, which in 2018, the World Health Organization recommended as part of the third stage management of to prevent postpartum hemorrhage. The active management of the third stage of labor, like most of us may know, involves the prophylactic administration of a teratogenic agent prior to placental delivery. So before the placenta is delivered, you give this drug, as well as delayed cord clamping and control traction on the back umbilical cord, so that you can have the action of the drug and which can generally prevent bleeding after the placenta is delivered. And these are done usually in settings where you have skilled birth attendants available. This most critical part of the active management of the third stage of labor component usually is most times, as advised by WHO, is giving oxytocin. We give 10 international units, either intravenously or intramuscularly. And this has been the tonic of choice in settings where even where you have multiple agents, and according to the WHO recommendations. Oxytocin has been used as the first line for PPH prevention and treatment. It, however, has its drawbacks. It requires the cold chain transport and storage. And in modern day Nigeria, you can see in the last few years or so, electricity and power supply has been quite a challenging to the whole country. And you can imagine if you have to keep these drugs, which need to be in a cold environment or refrigerated. Many a times you find out that these drugs may not be potent by the time you want to use it. And that's one of the reasons to why our figures are quite high, because most of the time we're just giving something that we think it's active, but it's not. So it requires a cold chain transport and storage. And these requirements are not universally available in all settings where we make it better, and specifically pose the challenges in our own environment. Currently, we know oxytocin and misoprostol, which are largely of some optimal quality, because if you want to look at many of these drugs, really, you find out that many of them are not real good quality. You go and buy some of these drugs, they'll tell you there's this version, there's that version, there's that version. And when you want to, most people who want to buy these drugs rather go for a cheap alternative. They'll tell you there's I don't want to give brands, but you know what I mean. There are different types. You find out you can have oxytocin that can cost you 10,000 naira. You can also get oxytocin that will cost you 100 naira. So you can see as the same thing goes with misoprostol. So you find out that a lot of these drugs that you think are going to be active, even if you keep them in their cold chain environment, you find out that they may not be as good as you think. So heat-stable carbetocin is a viable reshaping for optimal prevention of PPH. In settings like Nigeria, where we have compromised supply, one, and you have a cold chain system which is poorly, because of poor quality oxytocin and suboptimal PPH management, even when you have to use it. It's ever crucial to understand that healthcare providers should accept and use heat-stable carbetocin for prevention. It's for prevention. And what factors encourage correct urinary agents in health facilities? It was very important. We need to train our healthcare professionals. And then we know there's evidence-based recommendations that strengthen the use of PPH for PPH services. However, we have quite a lot of clinical guidelines. Even my society, the Society of Gynecology and Obstetrics of Nigeria, we have clinical guidelines. But many times, this does not usually translate to good practice, even when you want to, because, like I said, the giving drugs may not be good enough. So let's talk a little bit about heat-stable carbetocin. Heat-stable carbetocin is a long-acting synthetic oxytocin analog. So it's like oxytocin, but it's recommended, it's an analog of oxytocin, and is recommended only for PPH prevention. I will mention later about the contraindications, and you find out there are many things that it's not supposed to be doing that we are practicing and using and doing, which is wrong, and was recently added to the core list of reproductive health medicines of the WHO in 2019. It does not require cold chain transport and storage, which impaired when you use with oxytocin, which is an operational advantage in our low resource setting. Global, when it initially came out, it was quite an expensive thing. And but global efforts with manufacturers has allowed heat-stable carbetocin to be provided in public sectors in low economic countries at a comparable price to that of oxytocin. I'll talk about the price shortly. And several studies and systematic reviews have demonstrated the effectiveness of heat-stable carbetocin, including in low-income countries like ours. I'll mention a few of them. Notably, the randomized control trial in 2018, the Wooden et al. Study, popularly known as the Champion trial, demonstrated the non-inferiority of heat-stable carbetocin compared to oxytocin to prevent blood loss of at least 500 mils or the use of additional oxytocin in vaginal births. And the Champion trial, Nigeria was one of the countries that took part in it. It was largely a hospital-based study in many countries, including Nigeria, and it's and single in it's according to WHO, it's the World Bank is about the single low economy. It's about the best study looking at using these drugs in low economic country settings. Gallas et al. In 2018, using the Cochrane review, again looking at uterotonics for PPH, identified ergometrin plus oxytocin combination, carbetocin and misoprostol plus oxytocin combination may have some additional desirable effects compared with the current standard use of oxytocin. And that's why a lot of people still give multiple drugs when they have these patients. They first give oxytocin, find out it doesn't work, they give ergometrin, they pound them up with misoprostol, and that's not really how to practice. The two combination regimens, however, associated with significant side effects. Carbetocin may be more effective than oxytocin for some outcomes without an increase in side effects. This review actually incorporated 196 trials, mostly hospital-based, vaginal births over 56 countries, including some other high-income countries. The Vun et al., which was concluded in 2018, was a meta-analysis of randomized control trials, showed that heat-stable carbetocin is effective in reducing the use of additional ureterogenics and decreasing PPH, and also transfusion, which when used during cesarean section, because with heat-stable carbetocin, like I will demonstrate in one of the cases I'm going to present, with the case I'm going to present, can actually reduce the need for blood transfusion. Among included studies, I must say, none was conducted in low-income countries, but alone, looking at just low-income countries alone. But what we know about the Egyptian study, which was conducted by Berry in some time ago, which was conducted in Egypt. Now, if you look at heat-stable carbetocin, it's relatively costly compared to other ureterogenics, yes. I said when initially first came out, it was quite an expensive drug. But recent subsidization effects or efforts by public sector of low-income and middle-income countries have resulted in competitive prices. By looking at the 2021 catalog of United Nations Population Funds, it listed the price of a vial of heat-stable carbetocin as about 540 cents, which was comparable to the price of oxytocin, which was about 33 cents. Because of course the NFPA uses, so if you can convert to Naira, that will give you a good impression of what it is. But we know that, however, in recent times, the prices are almost the same. Against this background, with all I've mentioned, the World Health Organization has recommended heat-stable carbetocin in certain situations. And this includes when oxytocin is unavailable or of dubious quality, like I mentioned earlier, or there's no cold transportation and storage capability, or its cost is comparable to that of other effective uterotonics, and if there's skilled health personnel to inject it, because this drug has to be injected, and it's also injected with caution, and there's some conditions in which you cannot give this drug. Now, Society of Gynecology of Nigeria is affiliated to the International Federation of Gynecology and Obstetrics, which is FIGO, FIGO is actually the international body covering the practice of obstetrics and gynecology worldwide. And in 2023, they gave out a guidance or a guide or or some protocols on the use of stable carbetocin as an alternative to oxytocin in prevention of PPH. And we know that euthyrotonics are recommended for use in active management of third stage of labor, like the WHO has recommended, and is supported as the first line of drug when you need to give. But like I've mentioned several times, it needs a continuous cold chain preservation. Oxytocin is recommended for preventing and treating PPH, as well as induction of labor and augmentation of labor. In contrast, or carbetocin is only indicated for prevention of postpartum hemorrhage. So you can't use it for induction, you should use it for augmentation of labor. Okay, we should take that in mind. And the inappropriate use of heat-stable carbetocin is similar to other existing alternatives, can endanger the lives of patients. So we need to educate, we need to inform, we need to monitor, we need to have pharmacovigilance, and these are very important when we're using this drug. It is a eutherotonic recommended for PPH prevention, like I said. It should not be used for labor induction or augmentation. It shouldn't be used during labor at any time before the baby is born. There is no point, under no condition should you use this drug before the baby is delivered, because the effect on contractions to stop bleeding is quite intense. It's not given for women who have cardiovascular disorders, not given women who have liver or kidney disease, and in women with epilepsy. And according to FIGO, in women who have sensitivity to heat-stable carbetocin. Oxytocin, or in fact, oxytocin or any of its excipients. When we mean excipients, it's an inactive substance that serves as a vehicle or medium for the active ingredients of the drug itself. So let's compare a little bit about comparing oxytocin and stable carbetocin. And I'll just talk about the action and the storage. If you look at oxytocin, it can be given intravenously almost immediately. The action is almost immediate with peak concentration after 30 minutes. If you give intramuscular route, it's slower, it takes about 3 to 7 minutes. But it produces a longer lasting clinical effect of about 60 minutes, and the half-life is 1 to 6 minutes. But if you look at carbetocin, it's given intravenously or intramuscularly too, but the intravenous route has sustained uterine contractions within 2 minutes. So within 2 minutes, the action is already there. And it can last for about 6 minutes, and it's allowed and it's followed by rhythmic contractions for up to an hour. So up to an hour, you're sure the drug is still active. And its half-life is about 40 minutes. You can see a drug whose half-life is 40 minutes compared to 1 to 6 minutes. And intramuscularly, standard uterine contractions lasting for about 11 minutes. Then if you look at the storage we talked about, and like I said, it's not used for certain conditions, like induction of labor, augmentation of labor, prevention of postpartum hemorrhage, and treatment of PPH. I'll look at some studies on PPH. Okay, looking at some studies on PPH. If you look at this study on epidemiology of postpartum hemorrhage, it was a systemic review. It showed the incidence, looking at the incidence of PPH. It varies in both high and poor countries. And you can see from this, it's higher in Africa, Latin America. And there's more concerns in low and middle income countries. Of course, we have the higher incidence of PPH. We also have the higher incidence of anemia in our own studies. The one trial, which is an important one, showed that there's a problem with late presentations in our patients, in the patient studies. There was maternal anemia, and then they talked about poor infrastructure in many of the settings. From our practices and research, we know that our patients, most of the patients we see, it's important to have a normal hemoglobin level in them. The incidence of PPH is greater with patients who have anemia. Anemia magnifies the effect of PPH, of obstetric hemorrhage. Antenatal anemia should be diagnosed and treated effectively And it's good if you have parental therapy, which should be considered for women who do not respond to oral iron. Looking at blood transfusion, it's dangerous. Blood transfusion is products are usually not readily available. The uptake from voluntary non-remitting blood donors remains quite low, so people are not donating. And just still remain high risk of contracting HIV, hepatitis. And when there was COVID, even though COVID is not so much anymore, you can still contact it. And there's a risk of cardiovascular death following PPH. So we don't want our patients to reach the stage where we need to give blood transfusion. Study which looked at postpartum hemorrhage requiring blood transfusion and risk of cardiovascular disease later in life. We saw that there is that looking at comparing short-term and long-term morbidity. Many times you have to do surgeries and hysterectomies. This will require blood transfusion. We need ICU admissions. And then you have complications such as Sheehan syndrome, renal disease, renal failure, and cardiovascular disease. So we don't want to put our patients having such complications even if they survive. And then looking at prevention of and treatment of postpartum hemorrhage, what do we know and where to go? Maternal mortality and morbidity depends on prevention and early treatment of PPH. So we need to be quite fast when we see such patients. Look, in the confidential inquiry into maternal death from the UK, they found out it was doing too little, too late. Too little in the sense that IV fluids were not given enough, oxytocics were not given enough, blood and clotting factors were not also available. And then too late, you rush to start giving prostaglandins, you sustain too late, blood decisions are taken late, and to reach senior surgeons and anesthetists was a problem. And this also led to quite a lot of women dying, even in the United Kingdom. So I've talked about this, looking at deuterated agents. You can see that carbetocin, which is similar to oxytocin, duration it's more active, it's faster, and then looking at other agents as well. In a study looked at quality of oxytocin in products in identified low and high income and middle income countries, it was a systemic review of 8 studies, including Nigeria. It was found that a lot of the products identified were of low quality. They had such quality issues in them. In fact, some of them failed the quality tests. Only about 64% of them in these 15 countries out of the 559 samples actually passed the quality test from this study by Tolan in 2016. For the medical therapy or prevention of postpartum hemorrhage, we know that I've talked about oxytocin. I've talked about carbetocin. We know that there are other drugs as well. Ergot, misoprostol is also there. Carboplast, well available, and of course, tranexamic acid can also be used. So what's the role of carbetocin? It has been studied by WHO as one of the drugs for use in management of PPH. Said that it's a long-acting oxytocin and it's heat stable. About 3-4 years ago, I used to have carbetocin everywhere. People that have worked with me, some of them are here. I have one on my desk in my office. I keep one on top of my fridge, even though it doesn't have to be in my fridge. I keep one there's always one of my colleagues carrying one. I mean, some of them are here, they can bear me witness. And then wherever I do my practice privately, I always have it. So it's always available for me. And for me, I have certain conditions where I must have it. It's prevention yet, and there are some conditions you just have to have it because it has a long, apart from the quick action, it has a very long duration of action. And it's available in Nigeria, so why don't you use it? And like I said, it's a long-acting oxytocin. So if you now look at oxytocin and ergot alkaloids, those ones should be kept in the refrigerators to avoid degradation. They are heat stable. Oxytocin is heat stable. So you need it's stable for me. Yeah. So yeah. Sorry. Oxytocin has to heat stable formation of oxytocin was currently not available before, but it's available now. So in the old formation was not available. Previous formulation of carbetocin was stored between 2 to 8 degrees, and resource poor countries did not always have the cold chain storage. But if you look at the new formulation of carbetocin, it's stable at room temperature. It maintains a potency for about 4 years at temperatures of 30 degrees centigrade and humidity of 75%. It avoids the need for cold chain storage and logistics. This is a manual by WHO, which looked at prevention, among others, tonics for prevention of PPH, and it was recommended that the use of oxytocin was recommended for prevention of PPH, but the use of carbetocin is recommended for the prevention of PPH for all births in contexts where the cost is comparable to other effective retail tonics. And looking at this evidence, studies on evidence-based research on carbetocin, oxytocin has significant adverse effects when given on rapid high doses, which carbetocin doesn't have. And many a times you have to give infusions when you're giving your oxytocin for long periods. But carbetocin is a long-acting analog of oxytocin, and you don't give the drug by putting it in a drip and let it continuously run there. And this is WHO looking at telling us the injectable dose, which is 100 microgram given as startum dose. And then carbetocin is associated with reduced additional heterotonics in both high and low risk countries when you do cesarean section. And if you look at this tells you that carbetocin is more effective than continuous infusion of oxytocin in maintaining adequate uterine contractions, and carbetocin reduces the risk of major blood loss by more than 50% when you compare that with oxytocin. Carbetocin also significantly reduces mean blood loss compared to cytometrin, even when you do your vaginal deliveries. I mentioned the Champion trial earlier on, which was one of the largest studies using heterotonics, and it confirmed that stable carbetocin is effective as oxytocin in preventing PPH. It was conducted in 10 countries. Some of the investigators I've seen one or two of them already here, and 29,000 women. It led to the comparable reduction in blood loss while offering the added benefit of temperature stability. The Champion trial also found that stable carbetocin can last 4 to 10 times longer than oxytocin, enabling prolonged contractions with just that single 100 microgram injection, which could be administered intravenously or intramuscularly. And this actually reduced the need for multiple doses. Also, stable carbetocin for prevention of PPH also was found to be more cost-effective compared to other heterotonics. And this study in Kenya, which looked at the provider experience and policy insights into when the introduction of stable carbetocin for PPH. The main objective was to understand PPH prevention knowledge, experience, and perspective, including among policymakers and health providers in Kenya. The healthcare providers' knowledge, perception, and experience was assessed in this study. The findings demonstrated that the healthcare providers' knowledge, perception, and experience, coupled with the policymaker perspective, is key to using stable carbetocin. And this is one of the reasons why this particular webinar is being held by the organizers, so we understand it. Policymakers should find value in using stable carbetocin as it alleviates challenges with a cold when you don't need a cold chain. And the study also was found to contribute to the global knowledge to the introduction of life-saving commodities. This other study in Nigeria aimed to elucidate the current prophylactic use of stable carbetocin, oxytocin, and misoprostol in secondary and tertiary facilities. It was done in 3 states, Niger, in Nigeria, Kano, Niger, and Lagos. It was found to be stable carbetocin requires concurrent procurement and capacity building efforts to create an enabling environment. So we need to get government involved. Stable carbetocin is non-inferior to oxytocin and had fewer side effects in this study when they looked at it. I will spend 2 minutes and I'll quickly go through this case presentation. So one of the cases where usually there are, to me as a gynecologist, there are obstetrician, there are two cesarean sections I don't like. I'm scared of. I use the word scared. You say professors are not to be scared, but there are two I'm scared of. And people that work with me will tell you that it's also, they probably will share the experience with me. One is two previous cesarean sections, two or more previous cesarean sections, because you cannot predict what's going to happen. The second one is placenta previa, major placenta previa. The bleeding from those two procedures are enormous. It's worse off if you have two of them together, two previous cesarean sections with placenta previa. And it is more disastrous if you happen to have any of those conditions with a patient who's a Jehovah's Witness, who doesn't want to have blood. There's nothing you can do about it if you have this patient. So I'll quickly go through this patient. So Mrs. TK was a 39-year-old public servant. She was gravid 3 para 2 plus 0 to her life. This case was 2 years ago. We admitted her at 38 weeks because she had two previous cesarean sections, but she's a known Jehovah's Witness and had two previous cesarean sections and said she didn't want to have, her belief doesn't want blood. She can't take blood. So she's going to do two previous cesarean sections. Like I said, one of those conditions I just can't, the bleeding can be, and you can have any of this together with, the other one is having a woman that has a big fibroid. But these two previous cesarean section or more, to me, it's always a scary thing. In 2014 and 2016, she had previous cesarean sections at a private hospital. So we followed her up from 14 weeks when she booked, and but we had counseled her that, look, you're going to have a cesarean section at 38 weeks. And we also told her, because she knew she had to do a BTL because she needed to complete her family. So at 38 weeks, we admitted her for CS, and all the things were okay. We had built our PCV to 38%. We had informed the pediatrician and we had procured plasma, which is like an alternative for patients who don't want to have blood. So she had a lower segment section. We found a lot of adhesions in the anterior part of the uterus, well-formed lower segments, and we delivered a nice minimum size, 2.95 kilograms. The most important thing was that she had IV Carbetocin. And immediately blood was given, she had instant contractions, and it was sustained. The blood level, estimated blood loss was about 300 mils, and that was basically when we were trying to do other things for her, and of course, trying to get into the adhesions. But she didn't have any much bleeding. We did her BTL, and she was fine. She recovered immediately from her delivery, and she went home on the second day. She was already taken orally, and by the third day, she was home, and she did quite well. So what are my recommendations? From all this presentation, we need to get the federal government involved. They need to allocate funds to scale up the procurement and distribution of heat-stable Carbetocin. Now we have cheaper versions. I remember when there was a period where we were buying, I think this year, we still bought one for close to 50,000. But right now we have versions that are being promoted that are available, and they are much, much cheaper now. The federal government should allocate funds to scale up the procurement and distribution of heat-stable Carbetocin to ensure considered availability. Procurement guidelines should also be developed to the national and state levels with a focus on preventing stockouts and promoting equitable distribution, especially in local governments where the burden of maternal mortality is highest. They are doing free cesarean sections now in Nigeria. People ask you, they are doing free cesarean sections. Do they offer free cesarean section in where you work? The truth about it is that free cesarean section in Nigeria is not available everywhere. If you read about the document quite well, it's only available in the local governments that were said to have were contributing the highest number of women that were dying from maternal mortality. So if where you're practicing, you can't offer free cesarean section, it's a plus for you. Yes, the patients don't get it free, but it also tells you that you're doing the right thing, or your maternal mortality is low. So it's only available in places where the maternal mortality is highest. And that means you should keep doing what you're doing because your figures are quite low. Otherwise, where you have free other things, not just the but other things are free and the government is doing, you may have to pick it up from there. So you need to guarantee sustainable supply of the drug, and the government needs to play its role. The introduction of heat-stable Carbetocin requires concerted procurement and capacity building efforts to create an enabling environment. So we know heat-stable is non-inferior to oxytocin in preventing PPH. It has few side effects compared to misoprostol or oxytocin, and it's more cost-effective when you compare with oxytocin, misoprostol. We need to provide support for healthcare workers training in where you've been sitting high heat-stable Carbetocin into the drug reforming fund, leading to sustained procurement over time. We need to organize workshops and training of upskilled health workers. So societies such as SOGON, Society of Gynecology, and National Association of Nigerian Midwives should facilitate workshops on training. My president is here, my vice president is here. For the past, I think, 6 years or so, we have done projects that involve training of all grades of healthcare personnel. And one of our focus has been to train people on how to prevent postpartum hemorrhage. We have a current project on now by the which is rounding up now, a 3-year project, with the latest project. In fact, we have 2 projects now which look at training healthcare professionals on prevention of PPH. We have the Amplify projects that are ongoing now. So we continuously train. You have to keep on training and give skills to health workers on best practices, because the only way we can succeed is by driving down these figures. These training courses should be incorporated into pre-service and in-service curriculum of healthcare workers. They're going to conduct implementation research to assess worker acceptability of heat-stable Carbetocin, while also building the capacity of health workers in active management of third stage of labor. It's not just there to say, let's give this drug, but they must also practice how to manage the active management of third stage of labor, which also provides literacy materials to women. And now we have faster ways we can reach our patients. I can reach most of us can reach each other now by WhatsApp and other things. And it's important that other ways we need to educate our women and generate demand for health services within our local health facilities. In conclusion, preventing PPH is critical to improving maternal health outcomes of heat-stable Carbetocin. Offers a promising solution due to its efficacy and stability. By adopting best practices in its utilization and aligning it with the federal government strategy, stakeholders can work together to simplify, reduce the burden of PPH, and save the lives of countless women and others in Nigeria. And I think this is what SOGON and this group who has brought us together are trying to do. We need to bring all of us together on board. And you can see, like you and they said at the beginning, there are many other people that are at this meeting, and they're also trying to reach other stakeholders so that we can all move together. I get so embarrassed sometimes when I was Secretary General of SOGON, where you go for anywhere in the country, the first thing they will ask is, why is your maternal mortality rate so poor? Hey, this and that, and you start trying to defend Nigeria. Yeah, the second best in the world and all that. Together with eclampsia, pre-eclampsia, which is another aspect of projects that SOGON is training people on how to reduce maternal mortality by giving magnesium sulfate, etc. Together with trying to, I'm not saying use heat-stable Carbetocin for everybody. No, it's cheap, it's stable. We can use it to prevent postpartum hemorrhage, and we'll be good with that. We need to facilitate the implementation of heat-stable Carbetocin in low resource settings. Policymakers and program managers need additional information beyond its effectiveness. This includes the visibility of its use, acceptability by women and providers, and other healthcare system requirements such as policy change, staff participation of procurement and storage consideration. A synthesis of existing experience from low settings may also be helpful. I'm not, to my best of knowledge, there is no published review on looking at existing experiences from low resource settings. So we need to do that as a research question. We need to save the lives of our women. All women deserve access to care that can save lives. Thank you all for listening. Thank you so much. Any questions?
I think I will lead by saying a round big ovation to Professor Aimakhu. Thank you so much for that insightful. I thought I thought I had read up on each table Carbetocin, but then I can see that I've not read up enough. I've not read up enough about it. And I'm sure that there are a lot of questions to you, especially about the different recommendations that you have given. And we will take all the questions together. But how we will do it is this. The person mentioned something very important. He talked about facilitating its access to different places. He talked about capacity building for nurses, for doctors, for any licensed healthcare provider that will be in this step. So this is something that we are partnering with all the different organizations that are on this war against maternal mortality due to PPH. So before we go into the question and answer session, we want to touch a little bit on accessibility. So please give us 5 minutes, 5 to 10 minutes for my colleague Oladosun to show us exactly how we can access it. So immediately it shows us, then we'll go full-fledged into the question and answer session. Oladosun, are you ready?
Yeah, thank you very much, Yewande. Good afternoon, everyone, and we appreciate you for your presence at this beautiful seminar. In some minutes, I'll just be taking us through how to access our offering from ShelfLife, such that we can get all that we need for the PPH bundle at our fingertips. Now, in our PPH bundle, we have 5 major products or commodities that are enlisted in the PPH bundle, basically, and which comprises of oxytocin, heat-stable carbetocin, tranexamic acid, misoprostol, and calibrated drip. Now, those 5 products make up the PPH bundle, basically. And we want all facilities to have access to all these products as easy as possible, and which can be done just at the fingertips by getting online to shelflife.co, just as you can see on the screen. Now, you access, if most of us can have access to maybe another device, I wouldn't mind if we can do it together so that we can personally register on board ourselves to have access to all these wonderful products. So you just go online, go through the browser, shelflife.co. Now it brings you to a page that looks exactly like this. Now you can have access to more details about what we are offering. But to sign up to have access to the products, all you need to do is to click on the sign up that is at the top right side of the screen. If you click on sign up, it will take you to a page where you can fill in your details. You just scroll down and you see where you fill in the details. Now, because we are hospital owners here, and we can just look at this place where they wrote name of pharmacy and just input the name of your facility. So you can just type in any hospital you want, the name of your hospital, which goes in there. Then the owner of the hospital, the name of the owner of the hospital goes for the place where we have the pharmacy owner's name. Then an email address. Now, but for the email address, we prefer an email address that you have immediate access to, either the administrative email address of the hospital or the email address of the CEO or the HOD of the pharmacy department, because immediately after this sign up, you will receive a notification on that email address to set your password. So you have to do, and the duration for the setting of the password is timed, such that if it is not done immediately, every registration that is done, we have to be done all over. So it's an email address that you can have access to immediately. So the name of the hospital, the name of the owner of the hospital, the email address, then you reconfirm the email address, then the phone number of either the owner of the hospital or the admin, because all these details go to our database, so that anytime we want to do a delivery, we have the right persons to call at the right time. So you input the phone number. Now for the retailer type, Because we are hospitals, we click on the hospital. Then for country, you click on Nigeria. Now the state or region. So we want to know which state you are. You just click on it and there's a drop down and you look for, you can type in your state. Maybe for example, currently I'm in Oyo State. You type in Oyo State. Then, but you type in your own state or your region. Then the precise city that you are signing up from. For example, I'm currently in Ibadan and I type in Ibadan. So it brings a drop down of Ibadan. Then I pick Ibadan, Nigeria. So it immediately gives a GPS location of where I am. Now, but it will be better when you input your address, which is the next, point to fill. So please, at this point of address, we want a detailed address for easy delivery. Address that will get us exactly to your location. So you input your address here. Now, if, for example, if you are referring or you were referred by a person, maybe another hospital, a fellow doctor, a colleague, you can put the name of the referrer here. Now, for this, for all of us that are on this webinar, if we refer anybody again, maybe you share the link with anybody to introduce them to ShelfLife, such a person can input the name of your hospital as the referrer. So there will be some little rebates that will be added to your account from our hand at the office for referring somebody. Then at the last point, you just click on this box of consent that you consent to our privacy policy and every necessary details attached to registering on ShelfLife. Then you click Get Started. Now, after all these details have been imputed, and you click on Get Started, it will take you to a page that looks like this. Sorry? Okay. It will take you to this notification that your email address have been confirmed. For example, this is just a demo, and that you should check your email address to set your password. So immediately you can set your password. And after setting your password, it will take you to a page, the login page. If it does not take you to the login page, you can still go back to the shelflife.co. And at the top here, you see where we wrote member login. And you click on the member login if it does not bring it up. But this is where it will now take you to. So with this, you can have access to the ShelfLife platform. So for the username is the email address that you registered with previously. Then the password was the password that you have set, which you can input into this. Now, when we do that, let me just type in something here. So if you put in your details, for example, it will take you to your own ShelfLife page that has your name, welcoming you on board to ShelfLife platform. And this is, for example, what it will look like. Now, on the left-hand side, you see pages that we can have where you have the product, you have your wallet, you have services we're rendering, you have where you can check your accounts, you have questions that can be asked and other things. So this is what your page will look like on ShelfLife platform. Now, going through the page, on the home page, you will see a point where you have something like get credit. Well, later into the discussion, I will talk about it, because one of the things we are offering, we are not only offering accessibility or availability of products, we are also offering financing partnership with every institution, so that all all health institutes can have access to products, and finance should not be a total limitation for not getting the necessary products for their customers or their patients. So I'll talk more about the models of our financing later. So after this home page, you can now go to our page of products. You click on the products page. Now on the products page, we have access to close to 2,000 or 3,000 products generally. But for now, I just want to show us how to access the PPH product, which is still the same model to access other products that you might need for your facilities. So when it takes you to the products page, you can scroll down and you see many details on the platform that you can easily understand when you check through because of the time. Now you come to this point where they say full product list. At the point of full product list, at the moment, we have 1,872 products currently in stock of different brands locally and internationally. Now, for the PPH bundle, you can just go to this search space and type, for example, oxytocin. When you search oxytocin, it will bring you the oxytocin brand, the Rotex brand that we have in store, and you see it real time. The same way you can search for its stable carbetocin, and it will bring you the carbetocin real time. And other products in the bundle, the calibrated drip, same thing. For the tranexamic acid, the same thing. And misoprostol, the same thing. So you can just search for this for the calibrated drip. Now, after you have searched for these products, the next thing you do is to add to cart to fix the quantity that you want. So for example, based on the presentation we just had from Prof, let me put in carbetocin. Carbetocin. Okay, for example, if a facility wants to order for carbetocin, you type it, it brings it out. Then you go to your add to cart, and you fix. Currently, as at this moment, we have 245 parts of carbetocin in our stock. So you fix in your quantity. For example, let's say I want to buy 100 packs of carbetocin. Now it takes me this portion at the top right corner of the page that writes checkout. I can just click on the checkout. If, for example, I'm purchasing only carbetocin, but if we are to be purchasing more products, all you just need to do is to cancel the carbetocin, fix any other products you want to buy, say oxytocin, for example, and I see the oxytocin. I click on add to cart again. We have 8,504. Let's fix 100 for easy. So now the checkout product has become 2. That means if I check out, I'll be having 2 commodities that I want to purchase. 100 packs of carbetocin, then 110 packs of oxytocin. And it shows me the amount that I'm purchasing. Now, the next thing I do is just to proceed to checkout. Now, proceeding to checkout, it will show me the details of how many products I'm purchasing. I will see the name of the facility and the address to deliver to. Now, this is where I want to talk about our offering based on the financial part. Now, we can also see here the selected delivery date. Now, it will give us the date it will be delivered. But we can also select a preferred date that we want it to be delivered to us so that we can, maybe, for example, you want it to be scheduled or programmed for a week or so, a particular date. Now, we go to the portion of the payment. Now, for this, for the payment option, we have managed credit and the basic customer. Now, for example, for those that are basic are those that do either upfront payments or payment on delivery. So like this customer now has not been placed on any credit. So the customer only does cash business with us. So for the upfront payments, you click the upfront payments. That means you have to pay ahead before the products are delivered. And if it is payment on delivery, it says you make payments on delivery. I will look for an account now that has the third portion or the third option that shows the managed credit. So under the managed credit, we have an avenue to pick how we want our payments to be splitted out. Sorry, let me just look for an account that can give me that option.
You have 5 more minutes.
No problem. Thank you very much. All right. Okay, let's try this. So for the payment, for the managed credit option, we have an option where we can either pay instrumentally, weekly or monthly. And we see everything well splitted out on our page, such that you fix the payment model that fits you the best. Let me just fix it so that I'll just take us to that page and we understand what I'm talking about. So you fix a payment model that suits you, and with that, you can follow suit and make every necessary payment that you need to do. Okay, now this is the pay small, small. Now the pay small, small shows how you can pay instrumentally. For example, this customer has purchased some products and also has an available credit of what to purchase. And based on the value of the products that have been purchased, the customer can pay weekly Maybe for the next 4 weeks, we'll be paying 405,000 every week with no fee attached. Or for the next 6 weeks, we'll be paying 270,000 weekly. But anything beyond 6 weeks, when we go to 8 weeks, there'll be some added addition to it. It's just some little charges. And that's, as you can see, they are very minimal amounts that can be overlooked. So that is what it looks like to procure or purchase from ShelfLife. And as soon as you do this, the delivery will be done in less than no time under a jiffy. For example, I am based in the Southwest, and deliveries to Southwest are done within the space of 48 to 72 hours maximum. And you get the products delivered to your doorstep, and you just need to get it and be doing the payments gradually. So this is how to access the PPH products on ShelfLife. I hope I was well explicit enough to explain this to you. Thank you very much. We'll give time for questions. I will hand over to Yewande so that in case we have questions, we take everything together. Thank you very much.
Thank you very much, Doctor. Thank you very much for that, Doctor. We can take questions. We can take questions and answers now. So for those that have questions, you can ask your questions now. Before, as we mentioned earlier, we are doing this. We are going ahead because not only are we making products accessible, we are also willing to partner with organizations to facilitate this kind of conversations, education, increase knowledge to action capability for the healthcare providers. I think the first hand I had raised up since was Mr. Aminu Abbas. You want to go ahead with your question, please?
Good day to you all.
Good afternoon.
Good afternoon. My name is Aminu Muhammad from Zaria Local Government, Kaduna State. My question, what is the role of PPMB for managing PPH?
All right, thank you very much for that question. With respect to patient medicine vendors, we are very, so I'll answer it in two parts. First of all, we recognize the role of patient medicine vendors as the first point of contact for healthcare in low resource settings, in local governments or in areas in our nation where access to a doctor or access to a clinic or a hospital is not as easy as it should be. So the patient medicine vendor or even the midwife is the first point of contact for healthcare. In terms of when it comes to maternal health, we, as a pharmacist, and also because we are functioning with the licensing policies for Nigeria, we only make available the products that require prescription. We only make it available for community pharmacists, for hospitals, and for clinics. However, for the calibrated grapes can be stopped by anybody. So the calibrated grapes can be stopped by the patient medicine vendors. By the time we are having the next webinar, you will know more about the calibrated grapes. The calibrated grapes has become an essential for every mother at delivery. So that's the major place where the patient medicine vendor will come, because remember, Prof said something. He said that even the mothers or the women should be able to demand healthcare. They should know about all these options and be able to make demand for it. So if a mother wants to go and give birth and she wants to use the drape is calibrated or is calibrated in such a way that blood loss post-delivery is measurable. It's easily seen, easily measured, and it helps the healthcare provider to make fast decisions. So that is available to everybody, and it can be sold by everybody. It does not need a prescription. But for other components of the bundle that we have, which are misoprostol, tranexamic acid, stable carbetocin, we will only make that available to community pharmacies. But this,
I think this means even pharmacy, even PPMB can store Carbetocin?
It's a prescription only medicine. PPMBs cannot
Yes,
get
yes.
from us. Yes, you cannot get it from us in ShelfLife.
Thank you, thank you, thank you. But
All
they
right,
can
sir.
store the calibrated.
Calibrated drips, yes.
Thank you, thank you.
All right, thank you for your question. I think the next hand that was up was Mr. Joseph Duru. Would you like to go ahead with your question, Mr. Joseph Duru? Okay. Pending then, we have Mr. Sikiratu Kailani.
Okay,
Good
thank you
evening.
very much.
This is Joseph Duru on the line.
Oh, okay, all right, you can go ahead, sir.
Good evening, all.
Good evening, sir.
My concern is on the non-availability of these essential drugs, oxytocin and misoprostol, in primary health centers. So much so that mothers are given 11th hour prescription from the hospitals to go and source for these drugs. In most cases, before the husbands go around getting these drugs late in the night, the woman has put to bed, and some of these complications have arisen. So what steps are going to be taken to curtail this practice of the primary health centers not having these essential drugs at the risk of our mothers? Thank you.
Thank you for that question. That one is for us from the distribution end. And also, if there's anybody from the family healthcare here, you can chip in. For our own side, my colleague mentioned something in our app, which is access to financing. Since we started working with the other organizations that are working on, making more information available about management of postpartum hemorrhage or management reduction of maternal mortality due to PPH, we have made available flexible payment pattern. You will agree with me that the family healthcare center, they are doing their best, but funding might not be something that they have in excess. So because they don't have excess of it, there's not so much they can do. When they have the funds, then they make what is available, including even skilled personnel. So what we are doing with every private hospital, every government hospital, is to ensure that regardless of whatever you want to buy from us, you do not have to pay immediately. There's a payment pattern. So you agree to the payment pattern and we make the product accessible. We've been doing this for over 6 years. And our objective is to eliminate stockouts and also ensure the accessibility to the required medication. So that's what we are. That's our gospel that we are preaching, right? You come on the app, you talk to us, you buy the product, and you pay later. That's to summarize what I just said. So this is not just for private institutions, it's for the public as well. And some public institutions are already keying into this. If you, I mean, as many people as can spread the gospel, let's spread it. We are the first health tech organization introducing managed trade credits to the healthcare industry, such that financing is no more a barrier. We are the first to do that, and we are committed to ensuring that we continue to do it. So that's from our own end. For the government, Prof also mentioned that there are some places that are even saying, there's free maternal care. I was in a meeting in Lagos where they talked about if you have a card, a particular LASFRA card or so, you can deliver for free in Lagos. So government is doing all these things. Primary healthcare needs a lot of funds. But in case of where the fund is not there to drop it down, we are saying buy now, pay later. And so I hope that answers your question to an extent, sir.
You did, but can't they have even an ample to save life? when it's most necessary. The Prof gave us the instances where he has to carry around these drugs to show, one, he's a gynecologist, two, he cares for women's life. In case of any emergency, he is ready to take control of such situations. Can't our primary health centers have at least 1 or 2 ampoules to save life when it matters? Thank you.
Thank you so much, sir. I'm sure when they watch this recording, they will hear that plea, and I'm pretty sure that the government is doing their best to ensure that they can do this. Thank you so much, sir. Can we go to Mrs. Kuratu Kailani now?
Thank you very much. My name is Dr. S.K. Adu. I am an obstetrician gynecologist and a senior technical advisor with JPIGO. I'm currently the study coordinator for the AMPLI projects that JPIGO is working on. And my comments are in 3 parts. I'm happy that Professor Ikpeze, who is our SOGON president, is also online. I wanted to hear from you, in other countries, if tranexamic acid and heat-stable carbetocin is used during cesarean section. That's the first one. Then the second one has to do with, you have actually answered, but it's just about all the cautions that Professor O.Aimakhu provided during his presentation about heat-stable carbetocin. And I am glad that you have given a response to that as well, because when you were giving your introduction, you said PPMV from Kenya and Nigeria, they are on this webinar. So I wanted to really be sure that all the precautions are taken. When I was working with IPAS, I went around this country training community pharmacists as well as PPMV on misoprostol. And we were very clear on who is supposed to stock, who's supposed to just have an information, and the indications and the contraindications. And in spite of that, there were cases of misuse in which misoprostol dosages were not followed according to the gestational age, and they were disasters, if I can put it like that. So it is very important for us to ensure that, yes, heat-stable carbetocin is very good. It is important. It is core to the prevention, to the reduction in the rate of maternal mortality that we are getting from postpartum hemorrhage. But Nigerians, our coordination and management or regulation of drugs, I don't see it as very good, to the extent that the drugs will not get to those that are not eligible to use it, or those that are likely going to have issues while administering the drugs. Then the other one is on the last presentation. I was told about something like Wambo platform, where you can sit maybe in your central medical store or in your facility to get drugs. Is this similar to that style of drug management chain, drug chain management or supply chain management, Wambo platform? I don't know whether that is similar to what has just been presented. Thank you.
Thank you so much. Thank you so much, and apologies for not addressing it the right way in the beginning. Please, I think the first question was for Professor Eze, not me. Or if Professor Michael can take that first question, please, about the use of tranexamic acid.
Yes. Can you hear me? Yeah.
Yeah.
It's like you anticipate cases where you want to check. It's so clear from the human trial using tranexamic acid that tranexamic acid use the amount of blood transfusion and also reduce the amount of women that left. So,
Sorry, sir, we
but
can't hear you.
can you hear me? Am I
Yeah, now
audible?
we
Yeah, okay.
now.
So in the same way, like I'm explaining my case presentation, you can use stable carbetocin to prevent CPA in various sections. You do it, okay? You can use for both vaginal and various sections. I hope that answers your question. And then you talked about misoprostol. My problem with misoprostol is that there's so many different brands, and it's so difficult to know which one. Um, some people stick to a particular, people give misoprostol, and just doesn't work. I'm not saying it's needed, it may be needed, but at that point, you want it to help and it doesn't work. But carbetocin is prevention, and you can use misoprostol to also do the same thing. In terms of availability, it's still trying to make drugs cheaper. Okay, and that's why we are approaching the government. The government regulates a lot of things. They are regulate the tariffs on many of our products, and they should also know that they should make these things available for users as well. The other person spoke about people doing prescriptions late in the night, even though the question was not directed at me. But it's the same thing in every facility. Sometimes decisions are taken so late, and then patients are told to go and procure certain things at odd hours or odd days when they think that they are doing. Thank you very much.
All right, thank you very much, sir. Though it was a bit difficult for me to hear, but I got most of it. I want to add as well to the topic of being clear about who can access its stable carbetocin. So we working with the PACS, that Society for Family Health, via the PACS project, we learned about the different trainings that were done for patent medicine vendors with respect to maternal health and also use of misoprostol. In fact, when we started with this PPH bundle, one of the discussions that we had with licensed healthcare providers was even some nurses and midwives not using misoprostol optimally, the right way, because there are so many doses, so many routes, and all of that. We are very careful on our platform to ensure that we only sell particular products to licensed healthcare providers. We are very aware of the role that patent medicine vendors play, but we are also very aware of the licensing policies of Nigeria. We are a lot of us are pharmacists, even though it's an health tech platform, and one of our, we are digitizing supply chain across Nigeria, Kenya, and some other parts of Africa, some other countries that we started in. We are very, 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 very keen to ensure that we are working with the associations. We are working with Patent Medicine Vendor Association. We are working with PSN. We are working with PCM. We are working with ACPN. And for everybody, you can see when you sign up onto our platform, there's a place where you upload your license or you upload your certificate, and it is scanned from our backend before you can even place your first order. That is, of course, done very fast so that other placements is not hindered in any way. But without that license, you can't get access to some medication. When you are signing up on the platform, immediately you indicate that you are a pharmacist. We need to see that license, the registered premise license that you are a pharmacist. It's a place that the address needs to be verified by our sales officers on the field to ensure you are, so you can access prescription-only medications. If you sign up that you're a patent medicine vendor, we have a fantastic relationship with patent medicine vendor nationwide. We make sure we educate and we manage credit available to them, but we do not make prescription-only medicines available to them. We know that it can be gotten anywhere else, but it cannot be gotten from our own platform. I think about, so the last one you mentioned, Wambo. So I checked about Wambo. They are more of funding. We are not really funding. So we are under field technology itself. Field technology itself is what powers and maintains with the Nigerian Ministry of Health, NHLMIS, which is used for management and dissemination of consumables and medications across all the primary healthcare centers. The technology that has been done, that is being used, that's field. So field gave birth to ShelfLife. And ShelfLife, what we do is that we make all these products that we talked about and any other products that you might require in a hospital setting, in a community pharmacy setting, treated medicine vendor setting. We make it available to you from your phone. So while you are in your phone or you are in this meeting now, you can sign up. Once you are verified, your account is activated. You place your order. We deliver to you for free anywhere you are in the whole of Nigeria. Delivery is free. You can decide to pay on the app. You can decide to pay when you get there, or you can when we deliver to you, or you can decide to pay later by applying for managed credit. So there's nobody like us currently, even in Kenya or in Nigeria. And so it's not just funding. We just recognize that financing is a major barrier. As you can see, Dr. Cornelius Amazing mentioned that, there should be an ample for every pregnant woman that enters the delivery room. We agree. What can stop that from happening? Knowledge can stop that from happening. Finances can stop that from happening. We are working with different organizations to make sure the knowledge is available. And we are also working with the organizations themselves to make sure that finance is not a barrier, to make sure it's in every delivery room. So that's how we are different from any other organization. And signing up on our platform is free. We don't use collateral to give you credit. We use business data that you provide us. That's what we use. There's no collateral, there's no interest. Just agree to pay us at when we should pay, or we withdraw our stock. Simple as ABC. Do we have any other questions?
Yes, ma. I have another question.
Okay.
My question about time delivery. When to say you make an order before it is delivered, it's supposed to like 5 days, but sometimes it used to pass 1 day, 5 days. It used to reach 1 week. Sometimes until when you are calling some staff to remind them your order. That is the number one question. Then the second question, sometimes you used to, when you want to make the order, you used to see OS. That is the second one.
Well, it's not available.
Yeah. All right, sir. So thank you for that feedback. For people because our central store is from Lagos, and we distribute everywhere from Lagos by air, by air or by road. We don't do by sea, and we don't do under the sea, just by air and by road for now. Sometimes our third-party partners sometimes can delay in getting to places that are not in Lagos. For those that are in Lagos, they can't complain like this, because they get it that day or the next day. And when you see something that is OS, because we supply the whole of Nigeria, for that day or the next day, it might not be available, but automatically it's being replenished, and you keep checking and you see that it's there. And you see that it's available there. We also want to mention that for anybody that is interested in the PPH bundle, any hospital that is interested in the PPH bundle, we are partnering with trainers to train you and your staff for free on how to use elements of the bundle, just like we got from this webinar, how to use the PPH, how to use oxytocin, use of tranexamic acid and the grapes. If you are willing to buy the bundle or elements of the bundle from us, we are throwing in free trainings. We are also working, Prof made a recommendation about making this training routine. We are coming up soon with an initiative that will be funded by Field to have digital courses that will showcase something like what Prof has done, and will be certified, and those certified will be globally recognized by the necessary bodies. We'll be making this, we'll be talking about this to the SOGON and all the associations, for whoever it is, whichever association wants to come on board with us and make these digital courses available to the members of the association. Are there any questions?
Thank you, ma'am.
You're welcome. Any other questions? Prof, do you have any last words you would like to share before we close the meeting?
Hello, can you hear me?
Yes, I hear you.
Yeah, okay. So, well, the message is clear. I hope we can improve, get access to the drugs, even the PPH bundle and other the PPH drugs we talked about, the drips. Now we're talking about accurate measurement of blood loss, not just putting an estimate. And it's good that we use these drips to help in estimating blood loss as well. And Nigeria is such a big country. The only way we can improve our usage or in anything we do, especially improve the lives of our patients, by having sessions like this, where we have people who can also drive the message to other people. Whatever you learn from this kind of webinar, try and let others know. I'm sure the recording will probably be made available at some forum, some setting for everybody to get access to. So thank you very much. And I think we should just improve our awareness of the fact that we can actually prevent mortality from postpartum hemorrhage.
Thank you so much, sir. And thank you everyone for joining. We'll be sending you an email with the recording shortly within 24 to 48 hours. Thank you so much, and we look forward to reduce maternal mortality rates, calibrated rates everywhere, stable carbetocin everywhere, no more pure water to pack oxytocin. I used to do that when I was working at UCH, and we look forward to that. Thank you, everyone.